A few comments. I mean, as Rick said, the theme of this is kind of moving forward, which is always far more challenging than all sorts of fancy analysis of what's wrong with the system. So I thought I'd share a few thoughts as I reflected on this problem and how to also get beyond certain kinds of platitudes that every report for the last 25 years has said and so forth. As I think about trying to move forward towards building a sustainable, equitable system, effective system for the people who rely upon it, an area where I think we need to do a fair bit of work is figuring out how do you affect change when no one is in charge. Because we have a system in which no one is in charge. The ministry is not in charge. Various stakeholders aren't in charge. And whenever people pull out the examples of where people really successfully change systems, some of you have probably heard about the VA system in the US during the 1990s under Ken Kaiser, completely transformed what had been a dysfunctional system. Certain aspects of Kaiser Permanente in the States, certain aspects in China. I was reading these presentations about following the flu epidemic, just massive changes. The UK even, much more effective in creating change in the system. It's not always better, but they change it nonetheless. And the point is these are all command and control. The unitary states, the unitary systems, and someone says we're going to change, and they can tell people to change. At least the organization and delivery and so on and so forth. Canada, we can't do that. And I think we really need to, I'm hoping political scientists and others can come forward to really help us think more carefully about how do we affect change in a system that is a collaborative system, a decentralized system, and you can't just tell people to change. You've got to somehow create an environment and a culture that encourages change towards a more effective system. So that would be the one thing I think about, because in fact I think Canada has lagged behind many, many countries just purely in our ability to undertake reform at a system level. There's lots of good things happening on the ground at different places in Canada, but the ability to really undertake serious systemic reform, we have been stuck for a number of years. Second point, I think we want to, as part of this, I guess, try and establish more accountability, more effective accountability relationships, and I would say particularly with physicians. They often get picked upon. So I don't mean to zero in on them, except they do allocate most of the resources in the system, right? They're the ones who decide who gets in hospital and who gets the drug and so on and so forth. So we have to focus on them as a key stakeholder if we're going to affect change. And by greater accountability, I guess what I mean is both accountability in some formal sense to the ministry, to the publicly funded system, but also to patients and more broadly the system, in that, of course, historically they have funded fairly autonomously. It's not been right to question doctors and what they do, and they have successfully maintained a fair bit of autonomy. I guess what I foresee is a situation, for instance, in which, the ministry contracts with doctors, right? The ministry is an insurance organization. They contract to say, you can treat our beneficiaries and we'll pay you for treating our beneficiaries. It has not functioned as a contractual relationship historically. We negotiate, pay, and other things. I would hope we can move over time towards being able to say, well, you know what? If you're going to work in our system, if you're going to treat our patients and we're going to have that relationship, here are some standards of care, standards of your organization, standards of how you deliver services that we expect of anyone who we're going to be contracting with, just as it's typical in any kind of contractual relationship between a purchaser and someone who's providing a service. Accountability goes beyond that, but that's a group that I would particularly focus on. I think would be important if we're really going to affect system change. Primary care so far has induced doctors to join in these organizations, but really hasn't done a lot to affect any real change in practice patterns. Right? They're now in bigger groups. Some of them now hire other providers, other allied health professionals, and so forth. There are some minimal requirements about after-hours care and so forth, but it's been quite minimal. So a focus on accountability is part of that. People have mentioned this, and here again, I wish I could say more about how to do this. This is bordering on the platitude side, I have to admit, but a stronger culture of evidence and analysis. Historically, across the board in Canada, ministries of health have not invested heavily in building units that can undertake the kinds of analysis that's required to plan a system and oversee a system. And I compare that with something like Kaiser Permanente in the U.S., who has a huge health division that hires many, many analysts doing work directly contributing to how Kaiser makes decisions about the kinds of services they're going to offer, how they're going to organize their practices. And this will sound perhaps strange to some of you as an economist. I think we focus too much on financial incentives. I think we focus too much on trying to use incentives to induce the behavior that we want people to undertake. I think we have to pay careful attention to incentives. So it's not that I'm saying incentives don't matter. Incentives matter hugely, financial incentives. What I'm saying is I don't think we should rely upon them as the main motivator for change and for telling people what we want them to do. We need to create systems where people aren't penalized financially for doing the things we want them to do, and that can allow change to happen. So yes, more move from fee-for-service to capitation, because I think it allows much more flexible practice arrangements and a whole sort of other things, or blended arrangements. But I'm talking about where we say the way we're going to motivate and affect change is by carefully designing financial incentives, whether it be a pay-for-performance system or variations on that theme. There are some places for that, but I would argue they're quite limited. What we really need to do is to work on more organizational, cultural changes in how organizations operate, how practices operate, because that will affect real change, I think, that will be longer lasting. And I do think there's a danger over time when you rely entirely on incentives. It means, therefore, you got to get them right. Because if people get used to saying, I'm going to do what they tell me based on what the incentives are, if you don't get them right, you're nailed, because you've just induced a whole bunch of bad behavior. So I think incentives, we have to be very careful about the extent to which, again, we use them as explicit motivators. I think there's a broader set of a whole set of organizational and policy and other kinds of ways to try and affect change that we desire. And my last point, we'll come back around to some financing. As I said, I don't actually think financing is, our system of financing is the fundamental problem that we have to address. There are lots of questions about the level and so on and so forth, but basically a primarily single-payer, publicly financed system has a lot to say for it. There are a couple of things around that major comment, though. One is, of course, there are areas where we are woefully inadequate in terms of access. Again, we all know they're the dental, the drugs, the various allied health professionals, sometimes physiotherapy, psychotherapy, and so on and so forth. I think we need to be creative about how we can create better access to what are medically necessary services that currently are not funded by our system. And part of that is thinking, here I think we need to be open about the political reality of certain changes that we can make. Unfortunately, we have a system, healthcare is constantly expanding because we constantly can do more things for people. We live in a political culture in which you cannot raise, say, the T word, right? You can't raise taxes under any circumstances. Well, it's kind of tough. You've capped income, but we have a system that's naturally expanding for a bunch of reasons, some good, some bad. So I do think we need to think about creative approaches, in particular ways that somehow allow you, perhaps you to link increased payments into the system to better services, better access, and so on and so forth. And the key is, of course, we know we can do that one way. We just go for private financing, right? It will expand. The problem, of course, is this will lead to all kinds of trouble with equity, right? So it's how can we do this in a way, create and think about financing instruments that can maintain our equity focus, but give a bit more flexibility in how we think about raising money through our collective system. And I think a lot of careful thought has to go into that over the next number of years. So I'll stop there.